Welcome everyone on board. Actually, today we will continue with the topic of in the way that we started. We did a cardiac patient for anesthetist, a patient with respiratory and liver disease for anesthetist, a patient with kidney disease for anesthetist, and now today we will just discuss a pregnant patient. What are like if you have a patient who is pregnant and you have to anesthetize either for a surgery, um, any other surgery than obstetric surgery or obstetric surgery. So main focus will be on the any other surgery. Okay. How many of you have done any obstetric surgery in a pregnant patient? Anyone, please? Tayyab?
Sir, one ortho surgery of upper limb.
Orthopedic surgery of upper limb. Okay. So, when you were anesthetizing that patient, what were the points in your mind? Like what should be your
Sir, first uh, fetal. There is risk of a miscarriage like this one.
okay. This is one thing. What else?
And others are related to physiological changes of pregnancy, like aspiration risk, difficult intubation, and supine hypotension.
Okay. So,
And at the time of extubation, we used instead of glycopyrrolate, we have to use atropine along with the neostigmine.
okay. Why it is what is the reason for it?
Because glycopyrrolate, I think cannot cross blood, sorry, placenta, or it crosses very slowly as compared to neostigmine. Therefore, there is risk of fetal bradycardia.
No, it cannot cross. Okay. It cannot cross.
Oh, okay.
Okay. So, that is one thing. Then what else? Of course, there will be consideration related to that surgery. Okay. Any surgery consideration, whatever surgery you are doing, like you are doing orthopedic surgery, so there will be concerns related to orthopedic surgery. By the way, if you want to think that if you have an orthopedic patient, so what are the consideration which you can have for orthopedic patient?
Sir, orthopedic, for example, in this patient, upper limb surgery, excessive, there is risk of excessive blood loss.
Blood loss.
Second is if surgeon uses tourniquet, and
Tourniquet.
uh, uh, then complications related to tourniquet.
Okay. Pain.
Yes, sir. Pain.
Vascular injury.
Yeah, vascular nerve injury.
Nerve injury. We are just talking not only upper limb, embolism, both either fat embolism or thromboembolism. Okay. Anything else? Usually these are the things which will be there in any other patient. Okay. Tourniquet, bleeding, pain, vascular injury, nerve injury, embolism, and yes, bone cement in specific orthopedic procedures. Okay. And sometime they are taking bone grafts. Okay, so for that bone graft, the surgery, it will be usually from the site other than the surgical site. Okay, so this is just a brain exercise. I'm not teaching any specific topic. This is just how you have to tune your brain for a specific surgery or specific case. Okay, so now come back to the pregnant patient. So you said that there is risk of abortion. What is one thing is abortion if it is early pregnancy. Other thing is preterm labor. Okay, what else? Teratogenicity. Okay, fetal distress. Look, these are the things which you can consider about baby. Okay, so if you want to help the baby from outside, there is a term for that thing. What is that one? Have you heard about intrauterine fetal resuscitation? Any one of you have heard about it?
Yes, sir.
What is it?
Sir, this is the main goal is basically maintaining blood flow to the fetus.
Okay.
Keeping the mother hemodynamically stable because in placenta blood flow is not auto-regulated. It depends on pressure of the flow of the mother systemic circulation.
Like you will do either you will go give fluid oxygen. Okay, do uterine
Yes,
make
sir.
uterine tilt. You might, if you are giving oxytocin, maybe you will ask gynecologist may consider to stop it or even give tocolytics. Okay, so these are the things. If you are anesthetizing, maybe you can increase the fraction of oxygen you are giving. What else? What about maintaining the acid base environment? Because whatever gas placental exchange is occurring, there is either a concentration gradient or ionic gradient. Okay, so ionic gradient is affected by acid base balance. Okay, so you will be generally you will be avoiding medications which are passing the placental barrier. This newstigmine atropine is an exception. Okay, what is the clinical effect? Nobody, because how much newstigmine will be transferred and how much it will have effect on the fetal bradycardia, but theoretically, yes. Okay, we should be using atropine instead of newstigmine. Okay, so can you use, like, if you just think about it, because we are considering at the moment with reference to the baby. Okay, so now just think about it. Is there any problem with the IV induction agents or inhalational agents or neuromuscular blockers? Okay, with reference to babies, or any opioids, NSAIDs? These are usually we are giving to any other patient. Local anesthetics. Is there any effect to the baby?
Yes, sir. I would like to add, like NSAIDs are avoided due to risk of early closure of patent ductus arteriosus.
In fetal circulation, will it have effect? Because sometimes some questions remain unanswered. So do you think NSAIDs will cross placental barrier?
Uh,
I don't I need to reconfirm it. Okay. Anyways, we can think about your answer is absolutely correct. But I'm not sure whether NSAIDs cross the placental barrier or not. because I will just a second. I will show you. There is one article about it.
Sir,
Yes, yes, please.
they are contraindicated, I think, from 32nd week onward.
Okay. Yes, that's what I was thinking as well. Anyways, because these are the factors which will like placental surface area, placental thickness, pH of maternal and fetal blood, placental metabolism, uteroplacental blood flow, presence of placental drug transporters, and molecular weight of the drug, lipid solubility, pKa, protein binding, concentration gradient across the placenta. That's what I was telling you. Okay. Let's see here, because they will induction agents. Most commonly used induction agent in parturients in thiopentone. Okay, so all lipid soluble medications will transfer and can theoretically affect the Apgar score. You know, I'm really disturbed by the sounds. Please, if you can mute your mouse mic. Okay. So I'm sorry. So this is how, like, theoretically they can cause, but if you are having a surgery, I don't think so there is any effect. Inhalational agents, because lipid soluble medications will be crossing. Okay. So ionized medications with high molecular weight will not cross. Okay. So volatile readily, as they are highly lipid soluble and have low molecular weights. Okay. So if you are giving too high, what else, if sorry, this point I wanted to just thiopentone is recommended for induction agent in pregnant patient. Why? What is the reason?
One arm brain circulation.
Very good, because it's the fastest of
Uh,
induction agent. Okay, so if you want to use it for rapid sequence induction, the fastest agent is thiopentone. Okay. Nitrous oxide in first trimester, it has been associated with teratogenicity. Otherwise, you can give it. Okay, and this is more so if you are using nitrous oxide with like for obstetric surgery. Okay, and neuromuscular blocking agents will not cross because they are highly ionized molecules. Okay. Among the opioids can cause respiratory depression, especially if you are using, but if you are using it in a surgery, no, nothing will occur. Okay. You can use it. You can use it. Similarly, local anesthetic, no effect. Okay. So one is highly protein bound, and so it will not have so it will be through the systemic circulation if you are giving epidurally, so it will not have clinically much of effect. This local anesthetic can accumulate in fetus due to iron trapping if the fetus become acidotic because of this what you call double Bohr effect. Okay, double Bohr effect. Iron trapping occurs when the decreased pH in the fetus produces an increased portion of ionized drug, which is then unable to cross the placenta. Okay.
Sir, my question is, this iron trapping of local anesthetics is only for IV administration, or when we give local infiltration, this also causes iron trapping?
Actually, the thing is that if you are using IV lidocaine in that patients, it can cause,
Yes.
because any other route from where that route where the medication goes, whether you infiltrate in local, whether you infiltrate in a nerve block, whether you infiltrate in epidural or spinal, ultimately where will the drug go? drug will
Okay, I've got it.
ultimately come to the circulation. Okay, but the thing is that
Okay.
this is more of theoretical effect, because the drug levels which will be transferred to the placenta will not be that significant if it is from any other source, because it will be coming from the venous part, and it is going from the liver. There is metabolism, so it will not create any problem. That's why you never face any problem in giving spinal in a pregnant patient, or it does not cause any problem in the babies. Okay, but
Okay.
this is a point to be that's how we learn every day. That lidocaine, I was just thinking now, that if you are giving lidocaine IV as analgesic, as part of multimodal analgesia, I think you should be considering this thing. If this can be transferred, and this can cause some problems in the baby. This is the only thing which I have understood from here. Okay. uh,
Okay.
okay, so you see, that's what you were telling me. It may be advisable to use neostigmine with atropine rather than glycopyrrolate. Okay. So benzodiazepine, highly lipid soluble, unionized, they will try, and it can cause respiratory depression in babies. But all these stuff, actually, this is an article on placental drug transfer. So these are mainly related to the obstetric surgery rather than any other surgery. Okay. So I will come back. Okay. So other than that, now now the last point is left, but it is the most important, of course, that what are the physiological, pharmacological, and anatomical considerations in a pregnant patient which will affect the anesthesia. Okay, so actually, if you want to understand this thing, remember one thing: in same way you should prepare for elderly patient, you should prepare for neonate, you should prepare for peds patient, you should prepare for obese patient in the same way. Okay, and you will say that what is the change, what is the effect, and how you should manage. Okay, so I will give you few example, that for example, related to airway, what is the change? Yes, Tayyab. Anyone else want to speak out? Just raise the hand, please. Otherwise, Tayyab, keep speaking.
Okay, sir. Thank you very much. In airway, first of all, there is edema.
Okay, so what will be the
Uh,
effect? Like
as well
there will
as
be two
there is
two
a risk.
sort of two sort of edema: the soft tissue edema and the airway edema.
Uh,
Okay, so for soft
yes,
tissue edema, you have to do very careful. There can be injury, there can be
injury. Okay.
mucosal damage. So you will be doing careful laryngoscopy, and you will be using one and size less endotracheal tube. Okay, and for
Okay.
soft tissue edema, what will you do? That you will be making the ramp position. Not only ramp position has so many advantages. So if you have ramp position, there is tissue edema and large breast tissues. So they are creating hurdle for your laryngoscopy. So ramp position is very important, and it will help you a lot. We have discussed a number of times this ramp position. For anyone new, it is rapid airway management position, and in which you put a pillow in a way that this is the like head side, and this is the neck. So you will be putting the head in that. This is the patient. Sorry for my bad, but you are actually putting in a way that the external auditory meatus come at the level of angle of sternal mantle. Okay, so this will make, what will be the effect here? What will be its effect? There is one oral angle, there is one pharyngeal angle, and there is one laryngeal angle. Okay, so
Yes.
actually by putting this ramp position, that these three angles become easier to align. So that will help in laryngoscopy and ultimately intubation. So this is how you will be managing this thing. What other effect will be related to airway? Not directly related to airway, but related to airway. What is that one? There is a reduced FRC. Okay, there
Yes,
is
sir.
there is increased oxygen consumption. So what will happen? Patient will, the effect will be easy desaturation. Okay. So what will you do? Pre-oxygenation. Okay. So similarly, there is a risk of aspiration, because this is risk of aspiration because there is gastroparesis. Gastroparesis is because of
Progesterone.
very good progesterone. Okay. So what will you do? Acid prophylaxis. I have a question to any one of you. The people who are fond of reading Morgan, just tell me, is it written like that in Morgan? Do you understand? Because the business end is this one. This is how you have to, at the end of the day, that's how you should be knowing. Whatever you read, at the end of the day, the only, yes, Dr. Fatima?
Yes, sir. I read obstetrics in Morgan, and it is not explained like this. It is not
Yes.
explained. It is not in points. It is not in bullets. It is not bulleted. You have to read a lot of paragraphs to extract a lot of information. It takes a
Yes,
lot
you
of
are
time.
you
And
are
it's
very
just
liberal.
wasting time.
You are very Dr. Fatima, you are very liberal and very soft in criticizing Morgan. But the reality is that it does not give you anything. It's just
Yes,
it's a
it doesn't.
humiliation of your mind and body when you are reading Morgan.
Exactly.
Okay, so practically, I am just
Yes.
telling you because there are so many points. Now you people can just identify that that's how you have to think. Okay, like for example,
Yes.
similarly, because maybe I will not be able to chalk out everything, I cannot recall, but for example, there is increased coagulation factors. Okay, so what is the effect?
Yes.
There is risk of embolism. Okay, so what will you do?
Yes.
You will give VT prophylaxis. Okay,
Mm.
so similarly, you can make, there is change in blood volume, there is like um like you can make a lot of things similarly. Okay, so whenever you have a pregnant patient for any surgery, you will be thinking about the baby, you will be thinking about the physiological, pharmacological, anatomical considerations, changes with reference to change, effect, and how to manage. So this is what message I want to give you. And now the surgery, of course, next step will be the surgery concern. Like we chalked out concerns related to orthopedics, you can chalk out like neurosurgery, all the concerns which are there in the neurosurgery. You have to maintain the ICP, you have to maintain the cerebral perfusion, you have to maintain the factors which can increase cerebral blood flow or cerebral metabolic rate. Okay, so you will be maintaining the CO2, you will be maintaining the temperature, you will be maintaining the viscosity, you will be maintaining the O2 level, you will avoid venous engorgement and whatever. Like if you have a patient with trauma, patient is collapsed, so you will be doing the same ATLS or ACLS. If it is cardiac arrest, the only thing extra will be that the patient will need to have this peripartum cesarean section. If you are not able to resuscitate within 4 minutes, and 5th minute you will do the cesarean section. So this is one thing, you will be doing the left uterine tilt, and you will be compressing slightly a little higher up. That's it. And you will be having the CTG. If it is a trauma patient, you will involve the obstetric team for the well-being of the baby. And you can have, even for an elective patient, you can have throughout the procedure CTG monitoring. Okay, they can have a CTG monitoring throughout the procedure. You will consult the patient, you will take consent for any unwanted event. Okay, this is your approach. Your approach will be for dealing a patient. And then the smaller points will come, that which fluid you should be going, any extra monitoring, like this fetal monitoring will be one. And if you have any doubt, you can have invasive blood pressure monitoring, or other than standard 1, standard 2 monitoring, whatever you want to tell, you can tell. Okay, because these patients sometimes they are asking certain diseases like DKA in pregnancy. I have discussed before. You can find in the playlist. I have discussed in detail decay in pregnancy. Okay, so any question? Like, I hope you understand what message I wanted to give. And when even if you are evaluating the patient, few questions you will be asking will be related to the duration of the pregnancy. You will be asking about any history of placenta previa or placenta PIH, or any thing related to pregnancy, which the problems which commonly patient can have, like this patient who are having vomiting and too much nausea and vomiting. These patients can have effect on electrolyte, and if the patient is coming for surgery, you have to replace the fluids, and you have to be careful, because that patient can have repeated vomitings post-operatively, and it can create problem and increase morbidity in post-operative period. So this will be thing. Blood group and the rest of the demographics will be the same, like you do for any other patient. So any pregnant patient coming for surgery, pregnant, now you can have a sketch in your mind. Okay, these patients are coming for a number of time obstetric surgeries, not necessarily baby delivery. Okay, they are doing for SK stitch. So almost same of the concerns will be there, but you have to be careful about an exaggerated response of bradycardia, because this area is with the vagal supply. Okay, so this is how you will be anticipating, and you will be thinking. Any comments, any questions? Standard 1 and standard 2 monitoring. Standard 1 is the presence of a trained anesthetist with the patient constantly throughout the procedure. And standard 2 is like you are monitoring the blood pressure, non-invasive blood pressure monitoring, ECG, end-tidal CO2, SpO2. This is standard 2 monitoring, and temperature. Okay, and any monitoring other than that is extra, like you are measuring urine output, or you are doing neuromuscular monitoring, or you are doing neuro monitoring, or you are doing any pressure monitoring, CVP, arterial line. You can name any monitoring according to the system, any abdominal pressure monitoring, uh, anything other than standard 1, standard 2. Okay, so Shamail, are you fasting that you are not speaking anything?
No, sir, I am listening to your lecture.
Are you
I'm
sure?
not fasting.
I am not giving any lecture. This is not a lecture.
Yeah,
I am. Don't
it's
abuse
your
me,
discussion.
because remember one thing. Remember one thing. The people who attend the lectures, they don't understand anything, because lectures
Yes,
are the one which are conducted in our conferences and our big people. I am an ordinary person. I just want to clarify your concepts. Okay, because if I want to give a presentation, I will be sitting in front of the camera with a three-piece suit and a very beautiful presentation, and unfortunately you will not understand anything. I will be telling you big research papers and everything. Unfortunately, maybe I am not eligible to do that, but actually reality is that this is how these are the things which any one of you, even first year resident, wants the answers to these questions. How to respond to blood? Yes, the few things some things I'm recalling, that if you have a patient with the pregnant patient going into hypotension, so which vasopressor will you use? Which will be the prefer? Any vasopressor you can use, but which vasopressor will be a better one? Yes, Shamal.
um, I think phenylephrine will be better one.
Okay, Tayyab.
Yes, sir. I will also agree with the phenylephrine.
Any votes for my vote of ephedrine? Because I will vote for ephedrine, because
I have
phenylephrine,
read
Sir,
some researches that it causes fetal acidosis.
this is only this is one thing, but phenylephrine decrease the, it's a pure alpha agonist. Okay, so a pure alpha agonist can decrease the visceral blood flow or not?
Yes,
Okay,
and it can also decrease the cardiac output.
So this is not cardiac output really. Bradycardia, it is causing severe bradycardia, reflex bradycardia. So this is one thing. Actually, ephedrine will be maintaining the placental blood flow. This fetal acidosis actually is not clinically very significant. There is always a debate whether you should use ephedrine or phenylephrine. There is another, why there is another metforminol. I have no idea where metforminol is placed. So usually, if you ask me, the answer should be ephedrine. Maybe in some key phenylephrine will be written. Any other comments about it? Whether we should use ephedrine or phenylephrine? Any other comment?
Yes, sir. If we see that clinically, since many years we are using the ephedrine in the case of the pregnancy or seizures, if there's somewhat hypotension to be treated, I believe with the.
I'm sorry, I don't understand. You are saying that there will be seizure with ephedrine?
No. I'm saying that if there is any hemodynamically instability,
Yes.
so you clinically, I'm telling you this clinically experience that most of the time the anesthetist, they are using the ephedrine as well, right?
Yes. Yes, actually, there is a problem that back in Pakistan, because of a political case, they were using ephedrine for some illegal activities, and unfortunately, instead of solving that problem, they banned ephedrine. So I don't think so ephedrine is available in Pakistan these days, or it is available
Sir, it's
as a
available in some setups.
some setups. It is
And I have
available
used
as a
it.
controlled.
Yes.
Yeah, they are protecting like diamond ring. Okay. So anyways, this is one thing. Then if you have like what other complications can occur other than baby, but that patient is prone leaky capillaries. So patient vascular permeability is increased. Patient has high cardiac output. So patient can go in pulmonary edema if you are giving too much fluid. So this is one of the complication you can deal. Okay, patient was not diagnosed, but patient suddenly proved to have PIH. The blood pressure is very high, and there's the patient, if it is any surgery after 20 weeks, so patient can have peripartum cardiomyopathy. Patient can have this preeclampsia. So these things can occur. What else? Any fetal complication like abruption or premature labor or anything can happen like that. What else? These are the things which I think if I missed anything, just please remind me, because the aim of this discussion was just to give you a concept that how will you deal a patient if you happen to have a patient which is pregnant. Okay, so next time whenever you are dealing any pregnant patient, don't be afraid, and just deal as a like any problem which is there other than pregnancy. You will just make it 1 + 1 is equal to 3. 1 + 1 is equal to 3. You can have an obese pregnant patient, so you will be doing like more care. The effects will be more. Okay, so I think it is enough for today. So in similar fashion, we will try to have a session on pediatric in similar fashion. Okay. So there will be, if you are doing spinal, there is more chances of PDPH. Okay. Nausea, vomiting, opioid side effect, extensive neuroaxial block because MAC value is decreased. Okay. Sorry, local anesthetic values also decrease and MAC values also decrease. And during the pregnancy, is it good to use inhalational agents or bad? Because if it is an obstetric patient, you would not like to give inhalational agents because it can cause uterine relaxation, and it can cause more bleeding. But in a pregnant, in a like other obstetric surgery, actually it is helpful because it will be relaxing the uterus. Okay. So actually it is helpful. What else? Anyways, thank you very much. I think I will stop here. And for you people who, just a second. I will just take a minute to show you this playlist, and you will find here, because I had put all this renal disease patient, liver disease patient, respiratory disease patient, cardiac patient, and I think there are some optimization and anticipation before surgery and anesthesia. It was very good discussion. Anesthesia planning, how to plan the anesthesia. I will highly suggest you people to have a look. We had detail in too much detail. We had done this pre-operative, pre-op 1, 2, 3, 4, pre-renal. So there is a concept of enhanced recovery after surgery, and all the things you will be doing in pre-operative period. Okay, so I think this should not be in this. Anyways, I don't know how it came here. So this is one thing, and this is related to Gyne Obs. Where is Gyne Obs? Yes. So in Gyne Obs, we have discussed a number of topics, this preeclampsia multiple times. Actually, now repetition has been started. So I have done quick reviews, MCQs, and diabetic ketoacidosis in pregnancy, peripartum cardiomyopathy, liver analgesia, cardiac disease like mitral stenosis in pregnancy, so obstetric hemorrhage. So I will suggest you, all of you, please listen. If you don't understand anything, you can just drop a message that in this video we did not understand this point. So I hope it will help you. Okay, so tomorrow inshallah we will do in similar fashion. Yes, Tayyab. Yes, Tayyab.
Sir, my question is, when we are giving spinal for cesarean section, what is your opinion regarding giving sedation to the patient after delivery of the baby?
Actually, thing is that theoretically speaking, or medical legally, you should not give too much sedation because this patient is at risk of aspiration. But practically all medications we are giving ketamine, whether it is ketamine, whether it is dexmedetomidine, whether it is propofol, opioids. But actually, you have to be careful, okay? Because even delayed effect of spinal. Usually it will, like, after the delivery of the baby, if the surgeons are fast, so actually just after giving spinal, maybe after 15 minutes, for example, this is the time where still the effect of spinal mediated hypotension can occur, and at the same time bleeding can occur. And if you have given sedation as well, this can create further problem to you. Okay, so this is a problem, but actually this is totally practical experience how you deal it, because dexmedetomidine, people are not familiar of using dexmedetomidine, not everywhere, not every anesthetist, but it's a wonderful medication. That, like, I give you example for today I had a patient with cholecystectomy, recurrent. This was redo surgery for, they did partial cholecystectomy, and they, after maybe 2 weeks, they brought it for redo surgery with manipulation of the, so they were trying to do it laparoscopically and then open. So these days I'm just trying to have the concept of opioid free anesthesia. So I'm just trying to use wherever it's possible for me to give any block and use minimal use of opioids. So actually, just to blunt the stress response and the initial part of the surgery, I had given 25 mics of fentanyl, 2 milligram of morphine, 25 milligram of ketamine, and a small amount of midazolam. And actually, just after intubation, I had given erector spiny block. So I gave erector spiny block around level of T7, T6, T7. And throughout the surgery, I did not had to give any further analgesia. I was using a very, very, very minute dose of, maybe it was a nothing dose actually. It was only 20 mics per hour of dexmedetomidine. Okay. And patient, at the end of the surgery was around 6 hours. And at the end of the surgery, I gave another shot of erector spiny block. Okay. So patient was fully awake, conscious, absolutely pain-free. I asked the patient to breathe, just have a deep breathing, because they opened it. It was a laparotomy, you can say. Okay, so dexmedetomidine is an excellent
I, I will
medication.
I will endorse your discussion regarding the Dexmed. It's a really beautiful drug in the intensive care unit, as well as
Yes,
just now I came through the Saudi Arabia. So where you are using lot of opioids and all these things. So because of agitation, the other things. So once you are putting the Dexmed on that one, you will be quiet. Your pressure will be quiet. The only thing we had in the intensive care unit is caused somewhat hypotension and bradycardia.
of course. You know, my anesthesia technician was very eager. I was just literally begging her, please don't give atropine or don't give glycopyrrolate, because her heart rate was jumping between 47, 48, and up to 60. And I was saying, please relax, relax, nothing will happen. The heart rate, blood pressure is okay. Patient is relaxed, totally relaxed. Okay. So actually, there was no need, but still, when it was touching 45 and I had to go to bathroom, so I had to give glycopyrrolate. So I gave glycopyrrolate and the heart rate jumped to around 65 to 70. But dexmedetomidine, believe me, it's a miraculous medication. Dexmedetomidine will change the anesthesia after a few years. Okay, because opioids, all the bloody side effects of opioids will not be there. There will be no problem with the gut. Okay, and world is going towards opioid free anesthesia. So why can't we try it? Yes, there may be, in addition to this bradycardia and hypotension which you mentioned, another thing will be delayed recovery if you are using it even in higher dose, or you are using the other aspects as well, like you are giving high MAC values and you are counting with. I have faced a very terrible delayed recovery with dexmedetomidine as well. But then I understood how to use dexmedetomidine, because in that patient, this was an ENT surgery and they were asking me to have hypotension. And I used a little higher dose, and they did not tell me, ENT surgery, suddenly they say we finished. So suddenly they tell me they finished. So I was not mentally prepared for it. I did not close it in time, and patient took a lot of time for recovery. But otherwise, this is the only care, and you should have, don't give atropine if you have glycopyrrolate, because you don't want tachycardia. Remember one thing, you don't want tachycardia. So unless there is sudden dip in blood heart rate, you don't need to give atropine. Okay, if you just want the heart rate, like in this scenario, the heart rate is ranging around 50, and you want the heart rate to become like 70, for example, or 60, you can just give a small dose of 100 to 200 mics of glycopyrrolate, and your heart rate will gradually, you will see the beauty. So gradually, one by one, you will reach. I saw that heart rate from 50, it slowly reached up to 70. Okay, if I had given atropine, I would have just given a roller coaster to the heart of that patient. The heart rate would have become suddenly 110. Okay, and there is no use of atropine unless emergency, unless sudden trend of bradycardia occurs and it's going down. Then you have to give immediately atropine. Otherwise, it is better to use glycopyrrolate. And if you are anticipating, it is better if you load the patient with glycopyrrolate, so that when you are starting dexmedetomidine, I will suggest you in sometimes, if I see that this patient can have more, I just load the patient with glycopyrrolate. When I am starting dexmedetomidine, I just give a little bit of glycopyrrolate, so that the heart rate will increase from 10 to 20, and I will have more margin when I'm using dexmedetomidine. And anytime you can decrease the rate. Okay, so thanks a lot, all of you. So inshallah, we will meet tomorrow with a baby waiting for us for surgery. Okay, so thank you again. You remember one thing, that the purpose of these discussions is only to clarify concepts. Okay, so Abdul Shakur, where are you working, by the way?